Hi, good morning. I teach at Hostos Community College, but I've been a nurse since 1981, and I've worked with hospice for over 15 years. And what I find is that the perfect storm erupts when you get a pediatric case coming into hospice with the potential for ethical dilemmas. So let me review a little bit with you. In terms of healthcare ethics, in the United States, we also call these bioethics or medical ethics. And as healthcare professionals, we have a certain set of laws that govern what we're required to do and what we're not allowed to do. Within that framework of legal laws exist rules that are set forth by professional organizations, and those are called ethics. And the medical profession has set a set of 4 of these. There's 4 healthcare ethics. There's autonomy, beneficence, non-maleficence, and justice. In terms of the United States, what you'll find is that autonomy is key, that the patient is the one that makes the decision and is responsible to make that decision, hopefully with the guidance of medical professionals. But so long as they understand the consequences of their decision, they're free to refuse medical care, they're free to demand care, and that's the key thing, but they have to be a competent adult. In terms of beneficence, this is where you have the affirmative action to do good, to help someone realize what it is that they want to accomplish. The flip side of the coin is non-maleficence, and there's where it goes back to the time of Hippocrates, to do no harm, to do no evil to the patient. But they're complementary, and like I said, it's the flip side of a coin. This is where I believe you get the doctrine of the dual intentionality. An example of that would be if someone is dying and they require so much pain medication to relieve their suffering that the net effect would be that it shortens their life. It's allowed to be given to them because the morality is that you want to relieve the suffering. That's your intention. Are there any questions so far? In terms of justice, this is where not only does the nurse or the doctor treat everyone fairly, but as a society, how much of our limited resources do we allocate per patient, per disease? And you get into rationing and economic benefits. As I said before, in terms of the competent adult being able to refuse care in the United States, when I did my dissertation, on the right to refuse care in New York State. The earliest reported case I could find was Schlondorf versus Society of New York Hospital. And actually it dealt with medical malpractice. But in the medical malpractice case, Judge Cardoza, he's a very famous judge in the United States. He was later on the Supreme Court. But at this point, he was a judge on the New York Court of Appeals, which is our highest court. And he wrote that it's long been the rule that a competent adult has a right to refuse medical care. Through the years, this case has been cited by other courts, as well as the Supreme Court in a later case. So it's set in stone that an adult has the right to refuse treatment. What's interesting to me is that most parents think that they can transfer that right to their children, but actually they cannot. The state has the power. In the United States, we call this parens patria, where the state steps in as a parent and they can govern what will happen to that minor. So in 1944, again, this case dealt with Jehovah's Witnesses. When I was studying ethics, they said if Jehovah's Witnesses didn't exist, we would have to create them for the hypotheticals. But the Supreme Court wrote that parents may be free to become martyrs themselves, but they're not free to make martyrs of their children. And that's where the state steps in, when they believe that they're not getting what we would call proper medical care. And the problem with that is, how do you define that? How do you define what's proper or what's not proper? And in New York, there was a case back in 1990, and the judge that wrote this decision was confronted with a mentally retarded adult who had the IQ of a 3-year-old. And he was suffering from terminal bladder cancer. And the mother loved this boy. And even though he was institutionalized, she was an elderly woman, she continuously visited him. She never gave up, contact with him. And the hospital said to her, look, in order for us to stop giving him treatment, you must now become his legal guardian because he's an adult. And she did that, and she tried to get the cancer treatment stopped because the physicians, the hospital, and she believed that it was just torturing her son to death. And in fact, what happened was one of the state agencies stepped in, and they said, no, you have to deliver care to him. The judge that wrote this decision did it with good intent, but as a result of the matter of Storer, a number of patients were actually tortured to death. And it became a matter where doctors were going to court and saying, we will not comply with your court orders for treatment because we're literally torturing this person to death. And the problem is they're not dying. They're just being tortured because we're keeping them alive at the same time that we're giving them this treatment. What happened was as a result of this crisis, New York State passed a number of laws that dealt with how do you deliver care to mentally retarded and developmentally disabled adults in order to protect them so that care could be removed. There were no pediatric laws in place. And what the courts started to do is they started to use the laws for the mentally retarded protections and apply them to the pediatric cases. And while parents are deemed to be the appropriate decision makers, what happened was pediatric medical decisions are made according to what we call a best interest standard. So the clinician tries to determine what the patient would have wanted and how are their needs best met, and then they make these decisions. Any questions so far? Okay. Most of the time, what the courts determined was as long as there was a medical doctor caring for the child that advocated a course of treatment, they would not interfere. So there was a case where their child had spina bifida. The parents did not want to have an operation, and somebody from outside the family sued to mandate that the operation be held, and the court said, no, you don't have standing. There's a medical doctor caring for the child. They're using what they call watchful waiting. So there's a medical plan in place. We will not interfere. What happened in the matter of DH is something a little different. This was one of the few reported cases where a court actively interfered. DH was a child on a pediatric intensive care unit in Nassau County Medical Center, was suffering from a disease called Hunter's syndrome. And it's not necessarily that the patient was going to die from that disease now, but there was a terminal diagnosis. So the child was on a respirator, but he was alert and oriented, and he was watching movies when he was awake. And what happened was the mother was a Roman Catholic, and it was torturing her to see the child like this on a respirator. So she went to the hospital, and they had a medical ethics committee meeting on it. And the doctors on the medical ethics committee decided that it would be ethical to remove the child from the respirator. And there was a Catholic priest there. What happened was the pediatrician in the intensive care unit, as well as the head nurse in the intensive care unit, sued. They wanted the child to remain on the respirator, contrary to the mother's wishes. And the court was confronted with this, and one of the reasons they cited was that the physician who testified to disconnect the child from the respirator had never cared for the child. He got his information on Hunter's syndrome from a medical textbook. He'd never cared for anybody with that disease. And they were swayed by the attending physician as well as the head nurse. So they said, for now, we'll keep the child on respirator. If anything changes, we'll go back to that. So there were four things they wanted to do. They wanted to preserve life. They wanted to prevent suicide. That's a big thing in New York. There's absolutely no permissible suicide. They wanted to protect innocent third parties, the people caring for the patient. and they wanted to maintain the ethical integrity of the medical profession caring for the child. Which brings us to home care. I work in a hospice, and what happens when patients are being sent home, they're being sent home theoretically with the thought that they're going to have a peaceful death. And what happens is when it's a pediatric patient, it's the perfect storm for ethical conflicts, because with adults, most of the time they can communicate and they tell you what they want and you deliver care according to that. What happens in the United States is care is fractured. You may have a primary pediatrician, and then all of a sudden you're transferred to a tertiary medical center for cardiac treatment or cancer treatment, and a new pediatric team takes over. And then at the conclusion of that treatment, when they make the referral to hospice, you're sent to a hospice for care. Those physicians who took care of you before may not be in the picture anymore. There may be structural limitations because of insurance. There may be hidden agendas here where they were referred to hospice. They really don't want to come on to hospice. So what I submit to you is, as the nurse caring for them in hospice in the United States, what you really need to do is you need to approach this. One, how good was the communication to the family? Does the family understand what hospice is? Do they understand that this is a terminal diagnosis? Do they understand that this is comfort care? You have to understand, what does the child understand? There's various developmental stages. And what stage is that kid at in terms of their understanding of what they're confronting? What's the parents' understanding? Do they still hold out hope? Are they still praying for a miracle? Are they looking for a clinical treatment trial to get into? And then this is the key issue, is they're coming to us as strangers. Is there any healthcare provider that's writing orders for this child that actually knows the child, knows their history? And we, as nurses, we need to know what to do when we're confronted with one of these dilemmas. And what I would say to you is, it's never good to be the cowboy, to be the one that's going to stand up and make changes. But what you need to do is you need to know how to work within your organization. You need to know, where do you go with an ethical conflict? Who do you approach? And if need be, how do you escalate it? And that's the key issue here, the fractured care, and how do you deal with it as a healthcare professional. Are there any questions about anything?
How old was that child? How old was DH?
DH was, he was older than 10. You know, he was awake and alert.
Right, and they say in the literature, if they're 10 and older, then they have the ability to make decisions.
He had no input into this at all. This was a decision made by his mother. Yeah. Anything else? All right, thank you very much. Yes, ma'am.
So, in summary, a nurse could contact the ethics committee and create a meeting if there's a situation like you said, if there's fractured care, you need to know how to deal with it.
Right.
So can you give us some bullet points on
What you have to do, in New York law, what you would do is you would have to have the duty to first go to your organization, the person you work for. Like I work for Catholic Health Services. So I would go to Catholic Health Services, I would say there's a dilemma, and then they would have a meeting about it. They would have a committee that would be in charge of making these types of ethical decisions. I, as an employee, if I want to continue working there, would abide by that. On the other hand, let's say I felt that this was really counterproductive or somehow violated New York law, there would be a compliance officer within the organization that would be above that I would go to. Above the compliance officer, you always have the right to go to a state agency. And the state agency would be the one to step in and look at things. If that state agency took a look at it and said there are real violations of law and ethics here, they would go to court. And they would have standing to interfere with that. So it's a step-up approach, but you work within the organization, and then you go to the state agency that has oversight.
But in the hospital,
Right.
Anybody can call an ethics committee.
Right.
And so if there is a major clash or something, an ethics committee meeting can be a nurse could access the ethics committee.
Yeah, it's the same as here. I'm not advocating anything differently than what you're saying.
Yeah.
We're saying the same thing.
Right,
What I'm
exactly.
saying is that it's a channel, and what
Uh-huh.
you should do is work within the channels, as opposed to like
Yes.
calling up ABC News.
So in
Something like that.
agencies, you work with your own agency and then get a compliance officer and then the state agency and possibly court.
Right,
And in a hospital, you call for an ethics committee.
yes.
Yeah, thank you.
Yeah. Okay, thank you very much.